Tetralogy of Fallot (TOF). Tetralogy of Fallot is the simultaneous occurrence of pulmonary infundibular or valvular stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding aorta placed above the ventricular septal defect. Normally deoxygenated blood in the right ventricle enters into pulmonary circulation via pulmonary trunk for oxygenation. In tetralogy of Fallot, there is pulmonary infundibular stenosis that causes right ventricular outflow tract obstruction. So deoxygenated blood from the right ventricle, instead of going into pulmonary circulation via pulmonary trunk, bypasses pulmonary circulation and enters into systemic circulation via overriding aorta. This leads to cyanosis. Clinical features of tetralogy of Fallot: mild to severe cyanosis, which depends on the severity of the right ventricular outflow tract obstruction. More severe the right ventricular outflow tract obstruction, more blood bypassing the pulmonary circulation entering directly into systemic circulation. TET spells. TET spells are intermittent hypercyanotic hypoxic episodes with a peak incidence at 2 to 4 months after birth. Knee to chest positioning or in older children, squatting relieves symptoms. Knee to chest position or squatting, it causes increase in systemic vascular resistance, thus higher pressures in aorta forcing blood into pulmonary circulation. Cardiac examination findings: harsh systolic ejection murmur at the left upper sternal border, possible right ventricular heave and systolic thrill. Tetralogy of Fallot can also lead to heart failure, so there will be congestive heart failure symptoms. TET spells in TOF. TET spells are hypercyanotic hypoxic episodes. This is central cyanosis. This is peripheral cyanosis. Hyperapnea. Knee to chest positioning. Normalization of breathing and blood oxygenation. Knee to chest positioning increases the systemic vascular resistance, thus higher pressures in aorta, forcing blood into pulmonary circulation for oxygenation. So cyanosis will be relieved. Heave is uplifting of hand due to impulse. If you place your hand on the chest, it will be uplifted due to impulse. This is called heave. Thrill is a palpable murmur. A sensation of vibration will be felt at this point. This is called systolic thrill. This is ejection systolic murmur or tetralogy of Fallot. Diagnosis can be done prenatally due to fetal echocardiography. Echocardiography is the confirmatory test for tetralogy of Fallot. This is right ventricle, this is left ventricle. Here it is ventricular septal defect overriding aorta as it is placed above the ventricular septal defect. In this picture you can see there is surgical patch repair of ventricular septal defect and aorta is rightly placed above the left ventricle. Chest X-ray, boot-shaped heart. Here is the boot-shaped heart due to right ventricular hypertrophy. As blood is bypassing pulmonary circulation directly entering into systemic circulation, so there will be low saturation of oxygen on pulse oximetry, hyperoxia test. It helps to distinguish cardiac from pulmonary causes of cyanosis. In this test, partial pressure of oxygen is measured during the administration of 100% oxygen. When cyanosis results from a right to left shunt, the continued mixing of oxygenated with low oxygenated blood results in continued hypoxemia and low partial pressure of oxygen despite optimum oxygen supply. Simply hyperoxia test is used to distinguish cardiac causes from pulmonary causes. If on oxygenation, saturation of oxygen improves, it is a pulmonary cause. If on oxygenation, saturation of oxygen does not improve, it is a cardiac cause. Neonates, there is a connection between aorta and pulmonary trunk called patent ductus arteriosus. Due to patent ductus arteriosus, some of the blood from aorta can enter into pulmonary trunk and then enter into pulmonary circulation for oxygenation. This reduces cyanosis. So our first aim of treatment is to keep the patent ductus arteriosus opened. Prevention of ductus arteriosus from closing. Administration of prostaglandin E1 infusion keeps the patent ductus arteriosus open. Example, IV alprostadil infusion. The dose of alprostadil is 0.05 to 0.1 microgram per kg per minute. This will keep the ductus arteriosus patent. Treatment of TET spells. To treat TET spells, administer oxygen, for example 100% fraction of oxygen via non-rebreather mask. Oxygen will constrict systemic vessels while it will dilate pulmonary vessels, so there will be more blood going into pulmonary circulation for oxygenation, thus reducing cyanosis. Knee to chest positioning, squatting increases systemic vascular resistance, thus higher pressures in aorta, forcing blood into pulmonary circulation for oxygenation. IV midazolam once during TET spells. TET spells occur due to physical or psychological stress, for example during crying, feeding, or defecation. Thus midazolam can cause sedation which relieves the stress. IV sodium bicarbonate 1 milliequivalent per kg IV to correct metabolic acidosis caused by TET spells. IV fluid resuscitation. IV fluid resuscitation will increase blood volume in systemic vessels, thus there will be higher pressures in aorta, forcing blood into pulmonary circulation. Vasopressors, for example, phenylephrine. Phenylephrine increases systemic vascular resistance, thus higher pressures in aorta, forcing blood into pulmonary circulation for oxygenation. The dose of phenylephrine is 5 to 20 mcg per kg IV once. IV beta blockers, for example, propranolol. Propranolol relaxes pulmonary infundibular musculature, thus reducing stenosis. So more blood can enter into pulmonary circulation via pulmonary trunk for oxygenation. The dose of propranolol is 0.01 to 0.2 mg per kg IV once. Heart failure caused by tetralogy of Fallot. In heart failure, inotropic agents and diuretics are given to the patient. Inotropic agents, for example, digoxin strengthens the heart musculature. It increases the force of contraction of the heart. The dose of digoxin is 25 to 35 mcg per kg. The dose of diuretics, furosemide, is 1 mg per kg, maximum 6 mg per kg. Diuretics relieves the fluid overload. ACE inhibitors are not recommended in patients with TOF because they may decrease systemic vascular resistance and promote TET spells. Definitive therapy of tetralogy of Fallot is surgical repair. It should be performed within the first year of life, ideally under 6 months of age. Repair. Patch closure of the ventricular septal defect, ensuring correct aortal position above the left ventricle. Enlargement of the right ventricular outflow tract obstruction by resection of the obstructive infundibular musculature. If there are serious contraindications to surgery, palliative shunts can be used. One of the examples of palliative shunts is Blalock-Thomas Taussig shunt. This shunt connects subclavian artery and pulmonary artery. A palliative surgical procedure for TOF that connects the subclavian artery to the pulmonary artery with an interposed graft. Thus, deoxygenated blood which bypass pulmonary circulation and directly entered into systemic circulation can gain entry into pulmonary circulation via this shunt, so it will be reducing cyanosis. Prognosis without surgery. 50% of patients do not live past the first 3 years of life if surgery is not done. With corrective surgery, over 90% of patients live more than 25 years of age.